Euh, bonjour à tous. Il me fait grand plaisir de vous présenter Dr. Yu Qing Huang, qui est attachée de recherche clinique et doctorante en épidémiologie clinique et en recherche sur les soins de santé à l'Institut of Health Policy, Management and Evolution de l'Université de Toronto. Euh, et elle va nous présenter ses travaux sur l'évaluation du risque de la démence, les effets cognitifs, les interventions sur les effets cognitifs et leur intersection et, et les, excusez-moi. On va faire une présentation sur an evaluation of dementia risk, effective cognitive interventions and their intersection with social determinants of health in older adults with traumatic brain injury. Merci d'avoir accepté notre invitation.
Bonjour à tous. Je ne voulais pas vous presser du tout pour le temps, c'est juste que je sais que j'ai une grosse présentation, puis on est à l'heure de pause de lunch, fait qu'on veut être capable de finir ça à temps. Alors, je vais faire la présentation en anglais juste parce que je suis encore dans le jus de ma thèse, mais je reconnais quelques visages familiers. Je sais que vous êtes tout à l'aise avec l'anglais et n'hésitez pas à me poser des questions en français par la suite. Il n'y a pas de problème du tout. Comme je suis dans le jus, des fois, c'est plus facile pour moi de rester consistamment dans un langage. So my name is Jenny. I'm a geriatrician at St. Michael's Hospital. It's a downtown hospital in Toronto. I'm currently doing my PhD in clinical epidemiology and healthcare research at the University of Toronto. So today I'll focus on my topic of traumatic brain injury in older adults. I actually rarely read my thesis title because it's just too long, right, to read it. But we're going to talk about a few results of the scoping review and systematic review on cognitive interventions to prevent and treat cognitive deficits in this population. I'm going to go through various methodologies with you about my thesis work because I think it's really important to see how we approach similar topics, but especially having a more enhanced look at how we can do better health equity, TBI, GERI enhanced care. I have no conflicts of interest to disclose. I hope you hear me okay. Maybe just okay sign from the group. Okay, great, thanks. Usually find that the chronological order of a presentation is a little bit hard to capture a large audience attention. I usually like to put the bottom line of the key messages to take away for home at the beginning, and I'm gonna make sure to come back to these messages at the end because that's what you're supposed to get from this presentation, and hopefully it's really concise and clear. So hopefully by the end of the presentation, I would be able to convince you that TBI in older adults is a critical issue. It's a silent epidemic. This group has the highest incidence rate of TBI, and TBI, as you will see, is diagnosed not only by a head injury, but also by at least a not perfect GCS score, so a deduction on that Glasgow Coma scale. It's associated with short and long-term adverse events. I'm going to talk about these, the TBI-related delirium, the dementia risk, and we do have evidence around cognitive interventions that I will present with my work, but you're going to see that it's pretty vast, it's pretty heterogeneous, and it's unclear which cognitive intervention, for example, is effective or cost-effective in Canada. Again, as I said, I will integrate a lot of the health equity lens within my work. We're going to look at how individual and intersecting social determinants of health are influencing the outcomes and how we can use an intersectionality framework to better enhance TBI geriatrics equity-oriented care. So, like all medical training people like to do, we like to share with the clinical scenario. Please take a minute to imagine that you're the geriatrician caring for a patient called Jackie. She was admitted to the trauma service. She's an 81-year-old widow living in a subsidized apartment. She fell last night while going to the bathroom, and she was found by her neighbor friend 12 hours later because she wasn't able to get up on her own. She was admitted. She was found to have multi-site fractures and a traumatic brain injury. This is how I met Jackie as a geriatric medicine resident. So during her hospitalization, she develops delirium and acquires, unfortunately, new cognitive deficits. I would like you to take a moment to think about the following questions. What's going to happen to Jackie? Are there any cognitive interventions in your toolbox as a clinician to help her? Is there one that's the best for her? And what are the future, what does Jackie's future look like? What is her dementia rate? If we consider TBI as a chronic health condition, and what's her access to cognitive rehabilitation services look like? Will she get the TBI TBI specific rehabilitation services? And if she continues to decline with regards to her cognition and function, would she get the support services at home, such as home care or alternative housing, such as long-term care admission? Traumatic brain injury, with definition, is an alteration in brain function or other evidence of brain pathology caused by an external force. It is getting a lot of popularity in media because of the military-related, sports-related injuries, right? It's getting a lot of attention. But TBI in older adults is a big silent epidemic because even though this population has the highest incidence rate of TBI, they do not remotely get the same amount of attention. So as in this graph from Stats Canada, you can see that the incidence rate of TBI increases exponentially, uniquely related to falls and in the older adults population versus other motor vehicle accidents or sports-related injury. Being older adults accounts for 38.4% of all TBI-related death, 43.9% of all TBI-related hospitalization, and older adults remain the group with experiencing highest morbidity, highest mortality rates, slower recovery with longer lasting symptoms than younger adults with even more severe degree of TBI. I was going to try this poll question thing. I think it might be a little bit tricky, but we can try for maybe question number 1, number 2. If it's taking too much time, I may just go back to the questions. I do have them as slides. So just take out your phone for 30 seconds and scan that. It's basically my name with 723 otherwise for the website. I'm going to start with question number 1. A prospective study look at how many older adults sustain a traumatic brain injury on falls. So imagine Jackie who fell. What is her chance of actually getting a TBI? What is that percentage? So let me just activate it for a second. Okay, so I'm seeing some answers. That's great. Oh, yeah. It's okay. No worries. I'll just, I see the results. I'll give you 5 more seconds. Okay, I'm not going to be able to show the pie chart, but there's about 7 people who picked 23%. There's about the same amount for 37%, and maybe 2 people picked the last option, which was 51%. Just go back to the presentation here. Oh, okay, that's good. Okay. I will not try it again. It's taking too much time. All right, so it seems like the majority have picked the option B's and C's. So C is actually the great answer. We're going to talk about that. Sorry, I did not realize that this was obviously being recorded, and it does take a lot of screen shift, so we're not going to use the poll everywhere anymore. We're just going to try to go through these with the slides. So 1 in 5 Canadian older adults falls every year, and about 37 of these falls results in a TBI. So it's a considerate amount of people. And we know that aging is associated with changes in gait, in balance, increased prevalence of chronic conditions, comorbidities, and increased use of prescription medications. All these are independent risk factors for falls. And so the best way to prevent TBIs in older adults is really to prevent falls. I'm going to plug here the World Guidelines for Falls Prevention. This was published last year, and really we have to review these really well and know them really well as clinicians. How do we recognize TBI? How come it's always so poorly recognized and poorly researched? So to be able to care for older adults with traumatic brain injury, we really need to be able to recognize this disease entity. And so I think, maybe not helpful to the neurologists in this room, but I think a lot of us, we may forget, how can we actually diagnose TBI? So I mentioned a little bit earlier in the summary points that we not only need a head injury, but at least also a deduction on the Glasgow Coma scale. So which one of these could be a finding of that problem? So maybe I'll ask you to raise your hand if you think about A, B. Here, A, by the way, stands for loss of consciousness. B is post-traumatic amnesia. C is disorientation and confusion. D is presence of motor deficits. And E is all of the above. E, all of the above. Great. Amazing. So to be clinically diagnosed with TBI, one must not only have a head injury from external force, so getting that history of maybe falling on the floor, hitting the head against the wall, but also present with any of the following: alternate level of consciousness, post-traumatic amnesia, disorientation and confusion, and focal neurological signs. For example, if a patient presents after they hit their head on the ground or against the wall and is shown to have an abnormal neuroimaging or any of these presenting symptoms that I listed here, likely be diagnosed with TBI, but otherwise, if they have a history of a head injury without any type of additional findings, they do not qualify for the diagnosis of TBI. As you can see here with the diagnostic criteria, an older adult presenting with baseline cognitive impairment may not be appropriately diagnosed with TBI because these features are quite confounding with those of cognitive impairment. Here, as for the TBI severity, it is characterized by the duration of loss of consciousness. We can separate the categories of mild TBI, moderate TBI, and severe TBI. And so not only we have the duration of loss of consciousness, we have the post-traumatic amnesia that could also be measured in duration, and also the Glasgow Coma scale that we talked about. There are about three components: the eye-opening, the verbal response, and the motor response. For me, as a geriatrician, I'm the most interested in the effect of TBI on older adults' cognition and function. So cognitive impairment is one of the most common and persistent sequelae of TBI. It can adversely affect short-term and long-term cognitive functioning, especially in older adults with already age-related cerebral atrophy. So that shrinkage of the brain that comes a little bit with age, leading to accelerated cognitive decline. The acute phase, especially when we're looking at that first week of hospitalization, someone who has sustained a traumatic brain injury has about 46.3 to 69.4% risk of developing TBI-related delirium. TBI-related delirium is complex and poorly understood, occurring in a very heterogeneous patient population. So it's hypothesized to have a different pathophysiology than other delirium processes. In consequence, as geriatricians, when we think about multi-component delirium care, for example, that we know well, such as making them move, regular cognitive stimulation, regular family visits, these may not be ideal for patients who are actually experiencing TBI because they could cause sensory overstimulation and cause impairment of neural recovery, for example. In the long term, TBI is a risk factor for dementia. We're going to talk a little bit about that later, but it's also causing other related behavioral manifestation, which I will not cover within this presentation, but these issues will require a lot of informal and formal caregiving. So even though older adults continue to suffer a disproportionate higher clinical burden, they have the potential for cognitive and functional gain. I think as an early career geriatrician, I was quite shocked to see a lot of older adults rarely refer to specialized TBI rehabilitation. This was confirmed by a report card spearheaded by one of my mentors in Ontario. And I doubt it's only a province isolated problems. I know that was also something that was elicited in other reports in the US. But as system and healthcare providers, I think we really have to do a better job to remove a lot of the ageist beliefs that older adults' cognitive impairment, for example, are beyond the capacity of cognitive interventions. So we need to get them to the same quality of rehabilitation services that younger adults are receiving, for example. I think the potential cost effectiveness and evaluation of the functional gain from cognitive strategies to promote quality of life, avoid caregiver burden, and avoiding these care transitions, such as going to long-term care homes, should be explored to convince our policymakers. So this is a systematic review that I published a little bit more than, we published recently, but the work was done almost a year ago. So the findings of our systematic review was great to have that kind of groundwork for my thesis work. We talked about prevention and really treatment of TBI-related delirium, because in the hospital setting, it was really not well known what to do for these patients. And our primary objective was to evaluate the effectiveness of non-pharmacologic and pharmacologic interventions to prevent or treat TBI-related delirium in hospitalized patients. Our secondary aim was to evaluate TBI-related delirium intervention safety outcomes and adverse effects. TBI-related delirium has at least two processes. That's what's really hypothesized. So the first injury happens immediately with focal contusions, diffuse structural damage. And the secondary injury occurs a little bit later, over hours and days. It is characterized by the blood-brain barrier dysfunction. There's a bit of ischemia, oxidative stress, and ongoing structural and chemical alterations. So one of the structures typically affected by TBI is the cerebral cortex and the striatum. By affecting the striatum, I think we were chatting about this a little bit earlier, it causes a reduction in the production of the release of striatal dopamine. So that really disrupts the delivery of dopamine activity to many places, such as the hippocampi, which is the memory center. So we can see a little bit the symptoms and maybe how this type of TBI, this type of delirium is different from others, and how this type of injury has its unique properties. We included studies such as, the Annie language, but had to have at least a comparator group. And the studies have to have also at least one TBI subgroup with the outcome of delirium being diagnosed using the validated screening tools. So here are some examples: the CAM-ICU, the intensive care, delirium screening checklist, the Westmead post-traumatic amnesia, and the Galveston orientation amnesia test. Our population of interest was, again, the hospitalized patient, because, again, a lot of the guidelines were more a little bit about the outpatient care and not so much about the inpatient care, I'm showing a few examples. They may look a little bit smaller on your screen. Not too bad. Okay, I have a few examples of the screening tools. So this is the Westmead, and the other side is the Galveston. So as you can see on the questions, they're mostly consistent of questions related to orientation, such as what's the date today, how did you get here, and what's the plan of care for today. Our review was registered in Prospero. Our reporting followed the PRISMA guidelines, and the search strategies was developed by myself and 3 other co-authors. We were able to get the search strategies reviewed by an experienced medical librarian, and we made sure to search all the information sources such as Medline, MBase, and the great literature. We reviewed independently the screening at all stages and the risk of bias evaluation with the data extraction from included articles done following a pre-tested form to capture study patient intervention characteristics. We followed the equity checklist from the Progress Plus framework, published by the Cochrane methods, and we made sure to include as many social determinants of health factors in the data extraction and to guide our equity analyses. The risk of bias for these studies was done using the Cochrane risk of bias tools. As for the data synthesis, we initially planned for the meta-analysis of a delirium and clinical safety outcomes, but unfortunately, we were unable to do so because of the between study differences in interventions and outcomes. So when there's something called too much heterogeneity within systematic review articles, it's unfortunately impossible to perform meta-analysis. We screened over 20,000 citations and had to exclude most articles because they did not have a comparator group or did not formally assess the outcome of TBI-related delirium. But from the included studies, we pulled about 1,014 participants. And as you can see here, there were more men than women. The mean age was about 47. Just wanted to also add that here, I did not only restrict to older adults, because when we're doing that, it was basically giving no study, so we enlarge it a little bit to have all the adults, but I think it's really convincing, for example, that the majority has above high school education. The average GCS score was about 9.74, which represents a pretty mild, moderate severity of TBI. And lastly, the most common mechanism of injury was not falls, but mostly motor vehicle accident. So overall participants that we identified did not resemble Jackie. We did identify, however, the pharmacologic and non-pharmacologic interventions. So starting with the non-pharmacologic interventions aimed to treat delirium, we had the reorientation program. And then we also had the intervention bundle, which is a little bit similar to what I talked about earlier with the multi-component approach, right? We had to choose the right sedation agent. We wanted to optimize sleep and pain. We wanted to promote that early mobilization. Unfortunately, both non-pharmacologic interventions did not show statistically significant reduction in delirium duration, but the pharmacologic interventions identified, which were Precedex, which is a commercial name, dexmedetomidine, compared to propofol or haloperidol, and rosuvastatin and aripiprazole compared to placebos, were actually efficacious. The only thing I will say about these is the sample sizes for these medication studies were really, really small. Also, looking at the quality assessment, we had at these moderate to high concerns for risk of bias. Overall, the pharmacologic strategies were efficacious at preventing TBI-related delirium, but confidence in our findings really is limited by the small sample sizes and the concerns for moderate to high risk of bias for all included studies. As illustrated by our equity analysis, the applicability of these TBI-related prevention and treatment strategies is limited as studies really lack older adults and a diverse study population. The bottom line for me as a geriatrician, how I'm going to change my practice is I will know about all the non-pharmacologic and pharmacologic right now within the literature to treat the TBI-related delirium within the inpatient setting, but I'm also aware of their risk of bias and their limitations. So I will also wait for further inclusion of older adults, diverse adults, safety and clinical outcomes before implementation within my practice. So talking a little bit more about the JUICE, the thesis work, this is a bit of an overview of my study questions and the study designs associated to it. In summary, I have about 3 parts within the critical components. There's a retrospective core study using large databases. There's a scoping review and a model simulation and a cost utility analysis. So I'm going to jump on them right away. Starting with the retrospective cohort study, as you will see, I will evaluate the dementia rate of older adults with traumatic brain injury and their health services use. So that includes home care, going to older adults' home and delivering that formal caregiving, for example, and their rate of admission to long-term care homes. I have a question number 3 here for you. As per the paper by Papadis and their group published in 2022, which social determinants of health are associated with lower ability to return to the community? So again, being able to return to community is often used as a quality indicator for older adults because we get to preserve their quality of life as much as possible. And that's usually a very patient-centered outcome. So within that first year after hospitalization, after their injury, which social determinants of health would be associated with lower ability to return to community? So is it A, Black race, B, lower level of education, C, social isolation, D, late age of retirement, E, A, B, C, but not D, and F, all of the above? E, okay, that's great. You guys are awesome. That's really good. So my project number 1 is a little bit an extension of that first study that you saw, but we're looking definitely more long-term. So the questions I'm already interested to show you are, how do social determinants of health intersect with their rate of dementia? How do social determinants of health intersect with their health services use, home and community services, in long-term care home admission, for example? And since exploring intersectionality is such a critical component throughout my thesis work, I would like to define what it is. Intersectionality is really a methodology that can identify the relationships among individual identities and systems of oppression. But it should really be also used internally by research teams to reflect on knowledge production. So intersectionality is a theoretical framework attributed to the critical race theorist and feminist legal scholar, Kimberly Crenshaw. And Dr. Crenshaw was really talking about three principles of intersection. They like first that the social identities, for example, are not independent, but multiple and intersecting. For example, I identify as an Asian woman who is also an immigrant. So that's like almost three layers of, different social determinants of health being intersecting and not just additive. And secondly, people from historically oppressed and marginalized groups are the focal point of this type of research. And thirdly, intersectionality can help reveal disparate health outcomes because without equity, quality is very shallow. And so, as you will see from my thesis work, I'm highly interested in the impact of social determinants of health. And I hypothesize that a racialized older woman who is socially isolated with TBI is not going to have the same dementia risk as someone else without these factors. And her access to a cognitive intervention and support services may be limited. We know from different biological plausible hypotheses that TBI may increase the rate of dementia. How is it doing that? So it's using really mechanism of disruption of microtubule function or accumulation of tau and amyloid proteins. And so our primary question is, what is the impact of TBI on the rate of dementia? This question has been studied in younger and middle-aged adulthood, but never in the older adult population. So you're going to see with the PCOS question a little bit, those of you who do a lot of clinical epidemiology research, is what we start with. I'm looking at community older adults who are above the age of 65. We're comparing them, the TBI group with the non-TBI group, and we're looking at outcomes of rate of dementia, association, and intersection with social determinants of health from April 2004 to February 1st, 2020. Using social determinants of health framework from Progress Plus structure from the Cochrane methods, and knowing the limitation of the administrative databases, we really have to evaluate which factor we can actually obtain. So I know from ICS, which is our databases in Ontario, I can get their place of residence, their race, and ethnicity, culture, and language through some surrogate markers using their immigration status in the Ontario Marginalization Index. I'm going to be able to get their sex, but not their gender. And again, I can use neighborhood income quantile to get a sense of the participants' socioeconomic status. So our study is a retrospective cohort study with ICS linkage databases. The index dates for our exposure group is a TBI diagnosis. So the moment they get the TBI diagnosis through different diagnostic codes, we're going to be able to capture them. And the accrual window will be 16 years from April 1st, 2004 to February 1st, 2020. The look back period will be 2 years to be really able to identify the outcome of dementia, for example, and the total follow-up will be something like 18 years. So that is already a huge window because in the literature, there's nothing really talking about the 20 years after older adulthood, after the age of 65. I'm bringing your attention to some of the highlights of our inclusion and exclusion criteria. For example, we will be recruiting older adults living in the community and excluding those who are living in the long-term care or receiving palliative care before their index date, before their TBI diagnosis. And if they have been diagnosed with dementia before the cohort entry, unfortunately, I will have to also take them out. Our comparator population consists of individuals who have not sustained a TBI, because we're really trying to see the effect of TBI here. And we're going to be randomly assigning index dates to match the distribution of index dates in the exposed group. So this is a big slide. I mean, we don't really have to go through it. I'm using different statistical methods that are pretty fancy just to really be able to match the different groups. And to get a better sense of the hazard rate, for example, of the primary and secondary outcomes. Again, the primary outcome was really looking at the dementia rate, and the secondary outcomes is the rate to admission to long-term care and home care support services. So this is the last question, as per Schneider et al. So that group published in 2021. What is the hazard rate of dementia if TBI occurred in a younger and middle-aged adulthood? So A, B, C, D. So the dementia risk is about 1.44-fold. And really, what's really interesting in that study is we're already looking at, Black race being more affected than white participants. We already know that females being more affected than males, and we already have some sense of other, socioeconomic status, such as lower level of education or lower level of income. So it's just highlighting the importance of integrating all these things. So I don't have all the results yet for our primary outcomes, but I thought it would be really interesting to show you something that we're doing to analyze the intersection between social factors and outcomes. And we're doing that using something called the conditional inference tree. So it's a bit of a machine learning decision-based tree method, which is using regressions, a lot of regression to partition the data to identify the predictors and their effect. Because we're all interested in the relationships, and here we're really, looking at the relationships between social determinants of health and their outcomes. So their risk of dementia, their risk of being admitted to long-term care homes, for example. So I took, this is not all the sample that I had, but I had a few nodes that I was able to develop. And as you can see here, we're really checking which subgroups, so what type of intersection of social determinants of health would bring the risk higher than compared to others. So here we have the comorbidity count, we have age, and we can see that when it's more than 2 comorbidity count and with age more than 82, group D, which has a risk of 1.53, is much higher than group B, for example, which has a ratio of 1.28. So this is a way to kind of look at which groups are going to be the most effective, because at the end of the day, the health services that we need to deliver and how we are going to be able to convince our policymakers is by showing them this type of difference in hazard ratio. What's really cool here is also I'm able to graph the time to event. So these following TBI diagnosis and their dementia with the probability of their dementia and label their outcomes by checking their different risk of getting these outcomes. That was a lot, but anyways. Here I have project number 2, which is the scoping review. And really I was looking at the cognitive interventions to prevent and to treat the cognitive deficits in this population. So earlier with the systematic review, I mentioned that I was really focusing that inpatient setting because I saw Jackie, that was the question that I had specifically, but now I'm a little bit more interested. Well, I know that the literature is pretty vast and heterogeneous. Is there a way for me to capture the breadth of the literature to understand which cognitive interventions I can focus on? Because that's really cool to be able to recommend, for example, cognitive interventions for our occupational therapists to conduct or to refer them to these specific rehabilitation programs. So here I was really interested to understand how we can prevent and treat cognitive deficits in these patients, and especially considering the health equity factors again. And the main research aim was to identify the breadth of cognitive strategies that are available to them, and how social determinants of health could be incorporated within that cognitive strategy research cycle. Our protocol was published in Open Science Framework. Our methodology followed the JBI handbook for scoping reviews. And again, we followed the Progress Plus checklist for reporting of social factors. We collected as many social determinants of health as available in the literature in the studies that we included, following the Progress Plus framework. We screened about 8,000 citations, reviewed 333 full-text articles, and included 13 studies. Most articles did not include older adults or participants with a diagnosis of TBI. So it's very nebulous. They're going to talk about maybe a head injury, but they won't specifically identify if the diagnosis of TBI has been posed, for example, after being assessed by a physician. So the mean age of study participants was 64, and most had moderate to severe TBI. Study years range from between the last 2 decades, from 2002 to 2023. And the total sample size was about 29,400 patients, but only 17% of the participants were actually older adults with the post-diagnosis of TBI. And these studies came from 8 countries, mostly in East Asia, surprisingly, and North America. The study's design had ranged from pre-post studies, RCTs, retrospective cohort studies using administrative databases, and prospective cohort studies. They showcase 6 non-pharmacologic interventions. So cognitive stimulation, which is different from cognitive training. We had the computer-based training. We had in-person training as well. Rehabilitation program and palliative care consult. So here the palliative care consult was actually about, when the patient comes in, they wanted to see if the older adult was going to survive the hospital stay. And so getting already a sense of their care needs and being able to, see how their cognitive outcomes actually improve by just assessing their care needs, which I thought was really interesting. Around 77% of the studies had significant results following the intervention, but these studies really did not have a sustained follow-up. So after 6 months, these patients really just evaporated. We didn't know what was happening to these patients. For the pharmacologic strategies, they look at sleeping aids, kind of repeating the same message, that hypnotics, for example, would not be good for their cognition. And for other interventional strategies, we had the neuromodulation, so using transcranial direct current stimulation and using burr hole with saline irrigation, really to clear out that subdural hemorrhage, for example. In summary, we were able to identify 6 non-pharmacologic strategies from cognitive to olfactory stimulation, for example. We found 1 pharmacologic strategy of sleep aids use. So it could be any antipsychotics or benzodiazepines or Z drugs, and 2 surgical strategies of burr hole irrigation, neuromodulation, if it counts as it's not really a surgical strategy, but some type of intervention. And we were able to identify quite a few gaps within the evidence surrounding cognitive interventions. So we know that there were really rare older adults with diverse ethnic, racial backgrounds. Really, the most studies focus on moderate to severe TBI, so very few evidence papers with mild to moderate TBI, and very low reporting of frailty or needing long-term and multiple follow-up points. The last thesis project I'm going to show you, especially the methodology, because again, the result is not yet there, but it's a model simulation and cost utility analysis that will inform policymakers. And that's really from the results of the scoping review and the consultation with experts in the field. I think I interviewed about 100 TBI specialists, so from physiatrists, neurologists, neurosurgeons to general surgeons, and I was able to gather quite a bit of estimates. But starting with the question, which cognitive intervention would be the would not be the most, but would be cost effective in Canada? So like any economic model, it's really important to understand our target population, the strategies, and the model structure. I will conduct the economic evaluation of cognitive strategies across different health care settings. So from the emerge to their home and with outpatient specialized care, for example. I will simulate older adults. So when we're doing a model structure, we're really simulating older adults with TBI. And here with microsimulation, we're really able to capture patients' individual characteristics and compare the different cognitive strategies of them going through different health events. So we're capturing or adopting the perspective of the Ontario Ministry of Health perspective, and the time horizon will be lifetime. So from 65-year-old to 105-year-old. The discount rate, which is a very technical term, is about 1.5% annually, and we will conduct probabilistic and deterministic sensitivity analyses. When we do simulation of a cohort of older adults with TBI over a lifetime, that's about 40 years for them. Each month, so every cycle of a computer simulation, the patient may encounter a lot of health events. So cognitive decline, functional impairment, getting admitted to the hospital. And these are all associated with health utility changes. So their quality of life being perhaps lower in their health care costs. So every hospitalization in Ontario, that's about $2,500 per day. So all these add up. And so the computer takes all these months of the simulated patient being alive until death and multiplies that by the quality of life, the utility, to get these quality adjusted life years or the qualities. So I'm going to be looking at primary outcome of the quality of life adjusted years or qualities, and we're going to do that for each strategy along with their incremental cost effectiveness ratios and the net monetary benefits between the dominant and dominated strategies using a cost effectiveness threshold above 50,000 Canadian dollars per poly. This is very much what's validated within our country, and the secondary outcomes would be looking at life years, delirium incidence, dementia incidence, and long-term care admission. With everything that I just talked about, you might think, wow, that's a lot. Like, what are we going to do? Like, what are the things that you can think about as already problems or limitations, and how are we going to go through them? So some limitations that I thought about, and I think it's really important to consider, is that, with any observational study, such as the big cohort study that you saw, there's unmeasured bias. And so especially when we're using administrative databases such as ICS, the diagnostic codes are much better validated in the inpatient setting than the outpatient setting. Like in Ontario, for example, when we bill, a lot of times, a lot of the services rendered by physiotherapists or occupational therapists are not necessarily something that they can bill within that code. And so it's harder to capture. And so this might actually underestimate the prevalence of especially the mild TBI cases because they don't necessarily end up in the hospital setting. Our study will also largely capture patients who have had contact, with the physician, so more that direct medical attention. And, there's really no data right now for us within the administrative databases, at least, to stratify or differentiate TBI severity, because as you saw a little bit earlier, it's identified using the Glasgow Coma scale and the presence of post-traumatic amnesia. So our outcome of dementia rate is also contingent on healthcare interaction with the validated algorithm for dementia that exists within our database. And our secondary outcomes of long-term care home and mortality, though, are not necessarily based on purely the health care interaction. That's something that we can capture a little bit easier with databases. Unfortunately, we're not going to be able to assess if the older adults already have a cognitive decline that could be subjective prior to their encounter in the emergency department. For example, for Jackie, she could have already developed some type of subjective cognitive decline, or just never seek the medical attention to evaluate her cognitive concerns, which increase their risk of falls in the end of the day and increase their risk of TBI. So it's a bit of a vicious cycle. However, I think it's still really important. We come back to the case of Jackie. She experienced quite significant cognitive decline after sustaining a traumatic brain injury and required a lot of support from her caregivers. With my thesis work, I really hope to highlight traumatic brain injury as a risk factor for cognitive decline. I think that's pretty clear. And there are many, many patients like Jackie who are older in my daily practice who are under-recognized and under-researched. So the ability to shed light on these older adults and using TBI as a framework of a chronic health condition and using various research methodologies, I think we would be able to help clinicians counsel the risk to their families and the patients, for example, and identify cognitive intervention to help them preserve or improve their cognitive outcomes. Besides, I think we're really going to be able to conceptualize cognitive and functional gain from interventions in older adults with TBI and help them identify contributing factors and strategies for eradicating these systemic barriers. Our economic analysis will directly inform policymakers about effective strategy application and promote equitable health outcomes. Coming back to the key messages, I hope that these make sense to you now, and if not, please come to me. But TBI in older adults is a big silent epidemic. They have the highest incidence rate. Their main mechanism of injury is through the falls. TBI is not diagnosed just by a head injury. It takes a little bit more findings than that. TBI has associated short-term and long-term cognitive effects. So we talked about TBI-related delirium. We talked about dementia risk, and I'm going to be able to show you that risk even better when they sustain a traumatic brain injury after their older adulthood. And cognitive interventions exist. I talked about quite a few: stimulation, training, neuromodulation, and so on. It does remain still, questionable of their effects in Canada, but I think at least by doing a cost effectiveness analysis, we would be able to identify the best recommendation for our study. And I think that hopefully I was able to convince you to think about using the health equity lens with the application and trying to understand how individual social determinants of health affect or influence the outcomes and how that can enhance general geriatric care. Thank you so much for your attention. I would really like to acknowledge all these people who have helped me with the completion of this work. I'm sponsored by a few awards and the Clinician Investigator Program at University of Toronto. So thank you so much for your time. Yeah, thank you, Dr. Monchi. So Dr. Monchi asked about the interaction between TBI-related delirium and dementia. Is that correct? Yeah. So, I mean, delirium is already an independent factor for dementia. And we know that from other etiologies of delirium. So we know that from, if a patient comes in with sepsis and they develop delirium in hospital, that already increases their risk of dementia later in life. I think there's a lot of literature about that already. To ask about TBI-related delirium, personally, I don't have the evidence to show you that because TBI-related delirium is already highly under-recognized. And I think, that risk hasn't been yet evaluated, but I'm going to definitely suggest that it's probably there. Thank you. Absolument. Donc, il y en a des liens, je peux refaire une je suis chercheur une question par rapport à votre pratique de retraite qui va porter sur des interventions cognitifs parce que ça m'inquiète beaucoup pour plusieurs raisons. Au Québec, on forme nos étudiants en intervention cognitive, mais on sait qu'on devrait peu importe l'activité. Peut-être un peu plus en pédiatrie, encore là, mais on a de moins en moins de temps de faire l'intervention avec les âgés souvent ils sont pas tournés à la maison très rapidement. Notamment même dans des centres de pointe comme l'Institut d'adaptation générale et je serais même pas étonnée que les personnes dans la vie qui ont étudié n'ont pas de thérapie cognition. Donc, quand vous allez faire vos modèles, je ne sais pas tous ces dit, est-ce que vous faites des bases de données ontariennes, par exemple? Vous avez quand même des données solides sur le type d'intervention cognitive qui est utilisé. Puis d'abord, on peut avoir en débat qui se sujet à personne, mais même le choix d'intervention cognitive, les tailles des gestes sont plus connus. Il y a beaucoup d'inconnus autour de l'intervention cognitive, mais je suis très intéressée par comment réfléchir à votre modèle et son applicabilité, en tout cas, au niveau squelette pour le monde. Je pense à un enjeu. Merci beaucoup pour votre question. C'est une excellente question. Puis j'ai pensé qu'il y avait au moins 3 composantes à répondre. Fait que premièrement, par rapport à la méthodologie, je pense que vous vous demandez, un modèle est aussi bon que les inputs là qu'on met. Fait que si on n'a pas des bonnes données, qu'est-ce qu'on fait avec? Je pense que, premièrement, les données, on va les prendre concrètement dans ma thèse, on le prend de la littérature qui est moyen. On prend des consultations avec pas les usagers, mais les experts, fait que les gens qui sont comme vous, ergothérapeutes. Et on le prend aussi directement des paramètres qu'on a à TRI, qui est le Toronto Rehabilitation Institute, mais sachant évidemment que la grosse limitation, c'est qu'il y a très peu de personnes âgées. Ils sont à peu près moins que 15% de la population qui reçoivent pour les interventions cognitives spécifiquement au trauma crânien. Fait que ça, c'est une grosse limitation, mais je devrais aussi avouer que le gros avantage de toute sorte d'analyse économique, c'est que on ajoute je vais les dire en anglais, le uncertainty parameter. Like, so we are adding on ajoute en fait comme une fenêtre d'estimation. Fait que c'est pour ça que c'est cool de simuler parce que là, on peut ajouter plein d'effets. Puis comme on ne sait pas encore qu'est-ce qui marche le mieux, on peut commencer à comprendre comment la simulation aurait été. Puis commencer à dire, ben, peut-être qu'on devrait avoir plus de temps à garder ces patients-là avec nous pour faire ce genre d'intervention. Ça serait probablement des données ontariennes qui vont venir pour supporter le modèle. Fait que, évidemment, il y aurait des limitations à intégrer ce genre de modèle partout dans le monde et dans une autre province que Ontario. Puis la dernière composante que j'aimerais en parler aussi, c'est que je pense que si on n'est pas capable de faire ce genre d'analyse économique, on va encore moins avoir la chance de convaincre nos politiciens à commencer à mettre de l'attention dessus. Fait que oui, les données sont pas parfaites, mais je voulais juste commencer de quoi pour au moins dire, ben, there's things going on. We need to use cognitive simulation. We need to use cognitive training because otherwise ces personnes âgées-là vont rentrer à la maison puis ils vont attendre un déclin qui va certainement arriver.
Et est-ce que vous avez considéré dans votre définition d'intervention collective ce qui touche beaucoup les aides externes, en l'ensemble comme l'intervention collective, ça devrait aussi à plus de l'exploration de ce qui est besoin en train de
Oui, tout à fait. Malheureusement, je ne sais pas pourquoi les interventions qui sont family-based ou qui sont données par les proches aidants ne sont pas ressorties dans ma revue vous vous rappelez du scoping review que j'ai fait sur les TBI older adults? Ben, ils ne sont pas sortis. Je me demande si c'est juste parce que il n'y a pas encore assez d'évidence ou de littérature sur les personnes âgées avec le trauma crânien. Et que ça pourrait juste être un peu une limitation à ce moment-là. Et j'ai pas encore intégré dans mon modèle ces différentes interventions-là parce que j'ai pas été capable de les capturer à travers la revue de la littérature. Mais je pense que c'est une très, très bonne idée. Je pense que si j'avais la chance de voir ces études-là puis être capable de prendre d'autres estimés, ben ça pourrait bien aider.
Question brève. On sait que la définition du modèle de TBI ne nécessite pas l'hospitalisation.
Non.
Et on sait qu'un certain nombre de patients ont des traumatismes crâniens difficiles, sont relevés soit par des ambulanciers, soit par des proches. Il n'y a pas vraiment de suivi pour les proches. Il n'y a pas avoir d'informations. Mais par contre, il existe des bases de données liées aux interventions des discours qui n'apparaissent pas à l'hôpital. Et dans ce cas-là, est-ce que ça peut être une façon d'améliorer l'évaluation en termes de suivi? Ça pourrait implémenter des données.
Merci Thomas pour la question. C'est une excellente question. Malheureusement, il n'existe pas de base de données qui sont juste avec les ambulanciers. Puis on aurait en fait, comme je l'avais mentionné un peu plus tôt, c'est une grosse limitation. Ça serait surtout des interactions hospitalières. Fait que on va surtout capturer, en fait, je pense même moins les gens qui ont juste le concussion, le trauma crânien léger. Ça serait surtout des gens qui ont au moins un trauma crânien léger modéré sévère, qui auraient une interaction hospitalière. Pour être simple, par contre, notre base de données qui s'appelle NACRS, NACRS, ça capture les visites ambulatoires. Fait que s'ils sont venus voir toi comme gériatre, ils vont être capables de, tu vas mettre ton petit birling puis ça va sortir. Ça va avoir l'urgence. Mais non, les paramédics qui vont aller visiter chez eux, puis leurs proches aidants qui vont être capables de dire ça, malheureusement, ça serait pas dans des bases de données.
Oui. On a une idée un peu de l'instance, de la fréquence de la transformation. Est-ce que intervenir fait une différence? Est-ce que c'est très, très... Peux-tu nous donner un petit peu comment intervenir?
Merci, Dr. Cargoa, pour votre excellente question. Oui, c'est une très bonne question. C'est quoi le but de euh, chercher à faire des interventions s'il n'y a pas vraiment un effet modifiable, si on n'est pas capable de optimiser leurs outcomes? Fait que jusqu'à date, on sait qu'il y a certaines interventions cognitives qui fonctionnent. Fait que je pense que j'en ai mentionné quelques-unes. J'ai dit qu'ils étaient efficaces, mais le sample size, la taille d'échantillon est assez petite, puis il n'y avait pas assez de suivi à long terme. Fait que ça pourrait être un début de quelque chose. Mais je sais que ça peut, en tout cas, le temps restreint d'une thèse, on ne pourrait pas avoir la réponse à toutes les questions, mais je me suis un peu plus spécifiquement je regarde surtout le taux de TNC en premier, puis on regarde surtout le coût et l'analyse économique, fait que surtout là, un effet plus modifiable sur leur qualité de vie. Mais on sait sur d'autres études qu'il y a un effet. L'effet, c'est pas nécessairement quantifiable, ça dépend de quelle intervention on parle, mais en général, ça peut quand même réduire, on peut passer de peut-être 1,44 à 1,2, 1,1, puis on réduit quand même l'effet de TNC à long terme. Exactement. Ouais. On peut se demander pourquoi. Fait que ça a un rapport avec taille d'échantillon, ça a vraiment rapport avec le risque de biais. Puis aussi, c'est utilisé, on comparait le Précédex avec le halopuridol. Fait que je pense que j'ai pas besoin de vraiment convaincre les gériatres dans la salle que c'était efficace parce qu'on a choisi un très mauvais comparateur. Puis entre le propofol, puis on sait que le Précédex marche un peu mieux, c'est ça. C'est un champ à découvrir. On peut définitivement faire un programme de recherche à vie sur ça. Merci.